joint line and meniscal windows. Have patient supine with leg bent at knee joint. Grasp the proximal posterior lower leg with fingers. Find the patella tendon. Place thumbs on either side of the patella tendon. Follow the depression medially and laterally. Medial tibial plateau. Have patient supine with leg bent at knee joint. Grasp the lower leg from the front with fingers in the popliteal and thumbs in the depression of the joint line. If you press inferiorly, you will be palpating the tibial plateau. On the medial side of the patella is the medial tibial plateau.
If you follow the infrapatellar tendon distally, it will insert onto a bony prominence. This prominence is known as the tibial tubercle, also known as the tibial tuberosity.
Medial femoral condyle. Have the patient supine with leg bent at knee joint to 90 degrees. Place thumbs in meniscal windows. If you press upward on the medial side of the patella with thumbs still in the joint line, you will be palpating the medial femoral condyle. Adductor tubercle. Beginning at the medial femoral condyle, palpate medially and posteriorly until you feel a bony prominence at the distal end of the natural depression between the vastus medialis and the hamstring muscles. Medial meniscus. Have patients sitting with leg off edge of table. Internally rotate the tibia and palpate along the medial joint line. With internal rotation, the meniscus pokes out a little, and you should be able to palpate the soft prominence of this meniscus. Medial collateral ligament. This is a broad fan-like band that connects the epicondyle to the tibia. The medial meniscus is also connected to the MCL. The ligament itself is not distinctly palpable unless symptomatic. To palpate the region of the MCL, locate the medial joint line in the meniscal window. Move medially and posteriorly along the joint line. This should be the region of the MCL and will become very tender when there's a sprain. Pes anserin. Have patient over edge of table. Stabilize the patient leg by holding their leg securely over your own. Palpate the tibial tuberosity. Move slightly medially and posteriorly. Ask the patient to attempt to flex the knee while you resist. This makes the tendons more prominent. This group of muscles tendons are known as pes anserin. Just medial to the insertion under the tendon lies the pes anserin bursa.
The trochlear groove is the track that the patella glides on. To palpate, the patella will have to be moved laterally or medially. The patella, also known as the kneecap, is the large sesamoid bone that glides over the knee joint. The quadriceps tendon runs from the end of the quadriceps muscle to the superior pole of the patella.
The patella tendon is from the inferior pole of the patella and inserts on the bony prominence of the tibia, tibial tuberosity. Have patient supine with leg bent at the knee joint. Grasp the lower leg from the front with fingers in popliteal and thumbs in the depression of the joint line. If you press inferiorly, you will be palpating the tibial plateau. On the medial side of the patella is the medial tibial plateau. The large prominence of bone right below the lateral tibial plateau. Palpate the patella tendon and move laterally. Must have knee flex past 90. Palpate its smooth surface right below and lateral to the patella. Lies lateral to the femoral condyle. From the lateral femoral epicondyle, move your fingers inferiorly and posteriorly, following the joint line. The head of the fibula is at the same level as the tibial tuberosity, but is not on the lateral side of the leg. Easiest to palpate when the patient's knee is slightly flexed. Probe firmly on the lateral joint space with your thumb, and you may be able to feel the anterior margin of the lateral meniscus. Best to palpate with the knee flexed to 90 and the hip abducted and internally rotated, sitting with leg crossed. Thick cord-like structure that runs from the lateral epicondyle to the fibula head. Have patient with their knee at 90. The bicep tendon is a tendon on the lateral side of the knee that comes down and inserts on the fibula head. It becomes more palpable when you resist knee flexion. Is on the anterior lateral side of the knee. There are two ways to palpate. First, have the patient seated and tell them to dig their heel in the ground. Second, have patient with leg fully extended. Either way should cause the IT band to be more visible. Palpable across the neck of the fibula head.